6 o'clock. We're going to go ahead and get started. Hopefully everybody had a decent spring break. I think the weather here wasn't too bad. Tonight, we're going to be covering, I know I'd said, I think before we were going to do infectious disease, we're actually going to do toxicology tonight and infectious disease next week because they're both actually pretty long chapters. Toxicology, I think, is around 160 slides. The good thing is after these two, they're all fairly short chapters. It's just these two big ones we get out of the way. Shouldn't take long. A lot of it's pretty basic knowledge that we learned in EMT school. Maybe some new stuff that you weren't 100% sure about, having to do with maybe snake bites or different spider bites, or recognizing different signs and symptoms of some sort of overdose or some sort of poison or something like that. What I'll tell you as far as note taking, there are some things I highlighted in here in yellow. If it's yellow, it's probably worth maybe jotting down. If it's something you know, maybe don't take notes on it. Reserve your note time for something that you're not sure of or something you want to look up later on. Before we get started, are there any questions? All righty, let me get my screen shared here. All right, everybody able to see my screen and hear me okay? No issues?
Yep.
Yes.
Perfect. All right, so like I said, Chapter 8, Toxicology. We're going to dive a little bit into substance abuse. We don't dive a whole lot into it. We talk a little bit about alcoholism and recognizing signs and symptoms of that. Obviously, toxicology is something that we're not unfamiliar with. This is people that have potentially overdosed, whether it be on purpose or on accident, or this could be a poisoning as well. Think of, we don't talk a whole lot about kids yet because we haven't been through peds, but think of kids maybe getting into a cabinet, whatever it might be, drinking a substance or getting into a substance. It was funny, I was looking through a different PowerPoint today, and one of the things they brought up was Tide Pods in an EMS, in like a curriculum. I find it a little odd that that's now in a curriculum, considering that doesn't seem like it was too long ago. There are two big differences when we talk about poisoning versus overdose. Poisoning is, Drano, CLR, any sort of chemical, maybe even a chemical agent. And that's something we'll touch on a little bit more if you can attend the Texas A&M weapons of mass destruction training. You'll go through a whole lot of different types of poisonings and chemicals, as to where overdose is more of a pharmacological substance. Maybe, you take too much medication. Maybe you didn't mean to. Pretty common with our elderly populations. Younger populations, one of the big things is looking for maybe our benzos to help with anxiety. Thing that I see pretty frequently is Benadryl. People that overdose on Benadryl, SSRIs, antidepressant medications, those are all pretty common, and knowing how to deal with them. Children are going to be some of our biggest things when it comes to ingestions or any type of poisoning, is because they get into things and they don't know what they really are. As opposed to when we talk about overdoses, as you can see the number there, 80% of those are potentially suicide attempts. Whether it was successful or not, it's, and there are the patients, and God forgive me for saying this, but that take too much of a medication for maybe attention reasons. Maybe they truly don't want to commit suicide, but they want to take just enough of this medication to get somebody's attention or something like that, and then accidentally take too much. Next thing you know is it ends up being a suicide or a suicide attempt because the patient's unresponsive at that point. But knowing where to go or what actions to take if that ever happens. My biggest fear is with kids is what you see right here. If you have child locks, especially working in EMS, we should be, when we're going into people's houses, we should be providing this education to people. Hey, make sure these cupboards are locked, to make sure, that we don't want this to happen again. The good thing is a lot of chemicals now, you have to drink a lot of it to really get any sort of reaction. The problem is there are certain ones that, especially if it's maybe in a powder form or something like that, that can essentially cause a choking or some sort of anaphylactic reaction that's going to end up closing the airway of somebody. So children, again, it's not intentional, but they're curious. They like to get into things, right? When we talk about our poison victims, there's a difference in who I contact for a potential substance. For any sort of medication, I contact medical control. If I'm sure of a medication or unsure of a medication, or even a child has taken too much of a medication that was unintentional, I'm calling the hospital. I'm talking to a doctor because that takes some liability off me. If it's, kid got into, I don't know, and ate a whole bar of Irish Spring soap, that's maybe something I call poison control for. To me, that's the big difference, is really your substance versus a pharmacological agent. That's my two different things that I'm going to do. I can tell you on the side of caution, the Poison Control Center will always recommend potentially going to the hospital and getting checked out. That's why I usually, if it's something that I'm on the fence about, that I'm not sure, I'll usually call the doctor and be like, hey, what do you think about this? I can tell you most of the times that I've done that, the doctor's like, hey, have parents monitor them at home. Not a huge deal. If the kid changes or there's any change of mental status or they see the child becoming more sick, then yeah, we'll go ahead and make sure they're brought to the hospital at that point. Poison control, I have the number listed in this PowerPoint. If you don't have poison control in your cell phone, you should have it in your cell phone 100%. It's something that we can honestly frequent, especially with our younger populations, is making sure that we have access to really even identify substances. That's something that poison control is very good at, is, okay, I'm not sure what is in this. It's a brand name of, let's just say, drain cleaner. And I can read through the ingredients, sure, but I'm not a chemist. I can call poison control and be like, what are some potential issues they can see with this? What's the recommended treatment? It could be something as simple as, well, we recommend that, the kid drink a glass of water or something like that, and then be seen by a doctor. That way I have some sort of guidance. And again, if I'm unsure, I'm calling the hospital. Poison control is very good at helping with identify substances, but as far as treatment goes, we can't really put in our report. I was advised by poison control to use a saline flush to try to flush whatever substance out of their mouth. Poison control some of those people have no medical training. So you've got to be very careful with that. That's why if it's something that I think is potentially a medical issue, I'm going to call a doctor, because then I can get orders for what to do on that patient. Our 4 routes, like I said, anything highlighted in yellow, I'd probably take a note on. These are things we're going to be covering. Ingestion, so anything that's potentially swallowed, maybe that kid drinking drain cleaner, maybe that bar of Irish Spring soap. Inhalation, so anything that is inhaled, that's smelled. This could be something such as like huffing. A big thing for a while was people huffing paint or huffing Freon, so that they can get some sort of high off it. That'd be considered your inhalation. Any sort of absorption through the surface. There was a big, and you guys all know about it as well, when the whole thing with carfentanil came out, and it was, don't let it touch your skin, don't let it touch your skin. It's going to absorb through you, and you're going to end up getting an overdose. That's a whole nother topic for a different day. Maybe when we get to overdose in this chapter, I'll talk about a little bit. But and then obviously injections, and this could be something as simple as maybe our illicit drug users that are injecting themselves with a substance that isn't pharmaceutically rated or isn't recommended by the physician or isn't prescribed to them as well. Even if it's a medication, it's still considered illicit if it's not prescribed to them. They're still essentially injecting their body with an unknown substance because their body isn't familiar with it and it wasn't prescribed to them. Depending on how it's ingested or not ingested, delivered, is really going to play a role in the reaction time that we're going to see. Obviously, an injection is probably going to be a little bit quicker, especially in the case of, let's just say meth or whatever it might be, when they're essentially injecting it into the bloodstream. That's obviously going to be a lot quicker than surface absorption or inhalation or ingestion. Ingestion, most common route, just because, again, for those little kids, they get into things. Even adults. I worked as a mechanic previously, and I was always getting some sort of foreign chemical in my mouth. you're under a car the whole time, you get some, whether it be, oil, transmission fluid, brake fluid, brake cleaner, any of that, you always end up getting something in your mouth. Um, it's the most common thing that we see. Remember, ingestion also goes hand in hand with pills. It's still considered ingestion if somebody overdoses on a certain prescription. So a list of things that people potentially ingest: your cleaning agents, things we keep under the sink. That's what I categorize it as. Cosmetics. When you think cosmetics, I know you automatically want to go to makeup, but this could be honestly hair dye. It could be any sort of chemical, hairspray, anything really. Drugs, obviously we're familiar with that. Any foods that maybe could be poisonous, such as some mushrooms that like we'll go through later, some other different types of plants, or even some seafood, to be honest. Household products I kind of put in the same category as cleaning agents, things I keep under the sink. Petroleum-based or oil-based agents, and then obviously any sort of plant. There's not too many poisonous plants as far as we're going to see around, I'd say the Midwest. And when I talk about poisonous, I'm talking that can cause death. It's very limited on what we'll be exposed to or what our patients will potentially be exposed to. Our only concern would be if somebody has like a plant from out of the country or something like that. They brought, I don't know, a Venus flytrap that's the size of a freaking mattress. Yeah, that's a concern. Some things to look for if there's a potential involvement for ingestion. Obviously, any burn to the lips from any sort of chemical agent, tongue, throat, esophagus, those are all concerns to us because that is potential for airway swelling. Issue with that is we need to manage that airway really quickly if we're concerned about that, or we have an issue with that could arise from that chemical being involved in that certain area. Depending on what is ingested, sure, it might take a little bit of time, might not get immediately absorbed through their stomach lining. It might take a little bit more time. It has to go through their digestive tract. So just because the kid, ate half a can of Ajax or some sort of powder cleaner or something like that, and the kid's fine 5 minutes after, doesn't mean the kid's going to be fine 2 hours after. And that's something that poison control will be able to tell you if you're calling them, is what sort of time frame would we be looking at for this. Inhalation, pretty common. We should know what inhalation is. Anything that is involving the respiratory system, anything that we are breathing in. This doesn't have to be, like I said, Freon or spray paint like huffing. This could be a chemical agent maybe you use at home for cleaning. I remember as a kid, my mom used bleach for everything. I mean, my mom would use a whole bottle of bleach, I swear, clean the bathroom, clean the kitchen, whatever. And I can still smell, like when I think about it, I can smell that bleach smell or that ammonia smell. And yeah, if you're around it a whole lot, there's no ventilation or anything like that, that could potentially be an inhalation burn or inhalation injury. Some of I wouldn't even say common. Some of these are not common at all. Ammonia, obviously, if you're using it as a cleaning agent. Carbon monoxide is actually one of the most common ones that we will deal with in EMS. Chlorine, maybe if it's a hazardous materials incident, or maybe if it's maybe like a water treatment facility or something like that. I've been on a couple of those. In that instance, those facilities know what to do to make it safe before we can obviously treat our patients. Cyanide, which we probably hear a lot about if anybody works in the fire service, hydrogen cyanide, which is the materials of combustion of plastics and things that everyday household materials are made of. Freon, so what keeps our house cool, keeps our cars cool. There's different types of Freon. Back in the day, we used to use something called R12. We got away from it because it was horrible for the atmosphere. We went to a new one called R134A. Same thing. They said, okay, that's not worth it anymore. We went to a new one called Freeze 12, and that's supposed to be environmentally safe. We'll see. Mustard gas, nitrous oxide, tear gas, any sort of really toxic gases. What you'll notice is that a lot of these are potentially gases that can be used in chemical warfare. And they are ones that, again, if you can make that teak string, will be covered, such as mustard gas, tear gas, hydrogen cyanide, chlorine, Methyl, I always say anything with methyl is bad juju. Methyl chloride will also be covered during that class as well. Absorption, anything, again, this doesn't just have to be skin. This could be anything absorbed through the mouth, kind of like glucose. We put glucose under somebody's tongue or in somebody's cheek or whatever it might be, just for a route of absorption. We're not looking for them to swallow it. We're looking for it to be absorbed through those mucous membranes. That's still a route of absorption. Good example that they put in here, poison ivy. Obviously, you come into contact with the oil from poison ivy or poison oak. It's absorbed, creates that skin irritation, that itching feeling, start to develop those hives. Really just depends on the person and what their reaction is going to be itself. A big one here, and I should have highlighted this going through this, is our organophosphates. The reason for that, especially being in Iowa, is just for the simple fact that we are around organophosphates more than we think. Farm fields, any sort of gardening centers, like Earl May. It was probably 3-4 years ago that a crop duster was flying over a field in near Marshalltown, if I remember right. Was doing what it does, right? Treating with pesticide for the crop. Didn't realize that there was a field full of workers when it was doing it. And those 30 to 40 people, I think, ended up getting organophosphate poisoning. When it comes to organophosphates, biggest thing to remember to identify that is that those people will essentially have bodily fluid running out of everywhere. They'll be salivating, they'll be drooling, they'll have salivating and drooling, they'll have tears coming out, they'll have snot running down their nose. The acronym SLUDGEM can really hold true for that organophosphate poisoning. And that's where we would look at maybe our higher doses of atropine if it's in our protocols. They also have kits, which are called 2-PAM kits. And those 2-PAM kits are meant to treat organophosphate poisonings. I really don't know of any service that carries those, but they are out there just for that incident. I think hospitals carry them, but I'm not 100% sure on that. Injection, anything that breaks the skin surface. Easiest way to put it. I'm not going to categorize it as muscle, blood, vessels, none of that. Anything that breaks the skin surface is technically an injection. Our body, if it is not used to it, will try to reject it by having an allergic or an anaphylactic reaction. It'll try to push it out. It'll raise our temperature. We'll get hives. It dilates our blood vessels because it doesn't know what to do. It's reacting to a substance that isn't known to it. Most common, this could be a test question. Most common poisonings come from bites or stings. We should know that. Bee stings, spider bites, ants, any bugs that can essentially bite you, right? Happens a lot more often than we think. This word, Hymenoptera, is another word for saying anything that has a stinger, such as a bee, such as a wasp, yellow jacket, anything that's going to create a reaction. I would probably remember that word because that word did come up on my national registry. So if you got to take a note on that or whatever it is, by all means. Some of the other things that were more common to see, spiders, ticks, arachnids, or scorpions, I wouldn't say as much. Unless somebody's got a pet scorpion in their house or something like that. That's nothing we're going to run into here. Snakes, yeah, we have poisonous snakes in Iowa. We have rattlesnakes in Iowa. We have copperheads. We have water moccasins. These are all different types of poisonous snakes. Now, am I saying that we should become, zoologists and know what every single snake looks like and be concerned about, what snake bit this person? Not necessarily. I can tell you, I'm not a big snake fan. I'm not running down a snake to figure out what it is after it bit somebody. I'm not even getting out of my ambulance or whatever I'm riding in until I know there's no snake in the area. And then certain marine animals. I could talk a little bit about that when we get to it, just from my experience of living on the coast and knowing what animals we had to watch out for and potential complications with those as well. This should go without saying. I shouldn't have to beat a dead horse on scene size up. Look for things that are dangerous. We should, if it comes out as an overdose or it comes out as a suicide attempt or a poisoning or anything like that, law enforcement should be coming with us. We should probably be making sure that they're clearing the scene before we're entering, just because they're kind of like our canaries in a cave. I hate to say that, but um, suicidal patients, if they're truly suicidal, could get very upset very quickly if they didn't accomplish their goal, and now you just got in the way of that. So having law enforcement there is a must every single time. This goes for intoxicated people as well. Somebody that's drank too much. If any of you tell me you've never been on a drunk person call where the person was irate, you haven't been doing it long enough. Things we can look for when we're at the scene: evidence. Not so much evidence, paraphernalia. Looking for things that can lead us to what is going on with this patient. Empty pill bottles, needles, things that kind of draw a path for us. Empty beer bottles, empty liquor bottles. It's the same as if you walk in somebody's house, they're unresponsive, and you see a bottle of insulin on their table. Okay, that's the smoking gun, right? That's stuff we should be looking for. I'll tell you as well, if you get dispatched out to multiple people in the same household experiencing the same symptoms, I'd be a little bit cautious. That's one of those, and I've done it, I don't know how many times. I'll have that dispatch call them back, or if they're still on the phone with them, hey, have them come outside, have them meet me, have them walk out to my ambulance. It limits my exposure to anything. It gets them out of the environment. It could be a case of CO poisoning. Think of the time of the year. Is their furnace running? Is this, a water heater issue? Is this something that could be causing CO to be released into the air? So just things that we need to be thinking about when we're walking up thinking of scene safety. Primary assessment with our patients, obviously ABC trumps all, making sure that they do have an airway, that they are breathing adequately, and that there is no external bleeding noted, and that we do have circulation within the body. Especially when we're talking about any inhalation injuries, obviously an airway is always a concern. It's the same as if, we have a patient that's had severe burns to their face. We might look at taking that airway from them a little bit sooner, just for anticipation that airway is probably going to smell or swell up on us. So we want to be kind of proactive about that. Your secondary assessments, so going through like your sample, your OPQRC, all that. No sample, no OPQRC for your national registry, please. But I do more of a focus assessment based off of what's going on with the patient. I asked some of those questions. A good example that I gave was earlier today was somebody that had taken too much ibuprofen on accident just over a longer period of time. And what had happened was it was due to dental pain, so they didn't mean to. Well, a question you can ask that person, if they tell you, yeah, I've been taking ibuprofen for 6 months, it mixed with Tylenol, whatever it is. Okay, what are you taking that for? Well, I have really bad dental pain. Okay, how much of it are you taking? So now your questions now revolve around that one thing that they told you, that they're taking ibuprofen and Tylenol. So I'm kind of focusing my assessment around that. I'm heading down that path of thinking I know what's going on with this patient. All else fails, you're not sure, maybe it's an unresponsive patient or whatever it might be. You notice some sort of chemical or something like that, or some sort of agent. Obviously, protect yourself more than anything, but we might end up having to do a full physical exam of this patient if need be. Relatives and bystanders are probably some of the best information that you will get when it comes to patients that are maybe even suicidal, because they don't want to tell you the truth. They don't want to come clean about what they did. Oh, it was an accident. I didn't mean to take that much. Relatives around, hey, have you noticed them acting differently recently? Has anything like this ever happened before? They'll tell you everything because they want their relative to get help. So use them as a resource if you can. And again, if you're not sure what they took or what it's going to cause, call your local poison control center. I would say, depending on what the suspected poisoning or the overdose is, what the substance is, kind of dictates my scene time and dictates how long I'm going to stay and play with that patient. If it's a little kid that drank a bottle of Dawn dish soap, I'm probably not going to be in a really big hurry to throw them in the back of the ambulance and get to the hospital. I might spend a little bit more time. That's when I'm probably calling the hospital. Hey, this kid, drank half a bottle of Dawn dish soap. What can we expect? Okay, the kid's gonna be hiccuping bubbles for a year. Okay, is there any immediate threat to life or health? No. Have parents monitor them. If there's any issues, have them, either come to the hospital or check with their primary care physician. That's fine, as long as you are following some sort of path while you're on scene with the patient. And you'll know, and if you've been in EMS long enough, you know which patients are sick versus not sick, which patients need immediate transport versus which ones necessarily don't. Especially when you walk in, they're like, I don't know, I'm feeling okay. You think I really need to go? Those are ones I might spend a little bit more time with, do a little bit more diagnostic testing if I can, such as 12 leads or checking a blood glucose or stuff like that, before I give any sort of recommendation. Obviously, at the end, I always recommend them go to the hospital just to cover me, but that choice is ultimately up to them. I will say I don't know why decon is in here, because unless you get certified in some level of hazmat, you're probably not going to be deconning somebody. Maybe a rapid decon, and I could understand if it's like in the eyes or something like that. Maybe you're using a bottle of saline, you clear somebody's eye out. Yeah, that's still considered decontamination technically, and you're trying to remove the substance. If it's something in a powder form, brush as much of it off as you can. Obviously, without injuring yourself, just be careful of the weight of that powder, because if it's something that's going to disperse in the air, we might have just made two problems out of one. That's kind of a big deal. But generally, if it's something you think requires a serious decon, that should probably be done by a hazmat team if you're unsure of it. Another thing that they keep bringing up here, we don't really use it a whole lot anymore, but it's still technically in the national scope as activated charcoal, which is essentially a binding agent that we would give patients. It's the nastiest crap I've ever seen. It looks like graphite, to be honest. Um, it would essentially, whatever the poisonous substance is, whatever they potentially took, they would take this, it would bind to that substance, and they would either end up passing it through their digestive system or end up throwing it up, to be honest. There are the cases sometimes where maybe a patient has taken too much of something and they end up having to go to the hospital and get their stomach pumped as well, unfortunately. um, Antidote. So anything that's going to kind of counteract whatever is going on. I guess you could consider like anti-venom an antidote, just because it's going to counteract, that poisonous venom that a snake or spider or whatever it is delivering. So that's really your reversal agent, is your antidote. It really depends on what it is, if a place is going to carry it. I said earlier to some of the people in class today that we're fortunate that we have a zoo here, because I'm pretty sure, and I sent an email actually out to Mercy today and I haven't heard back yet. I'm pretty sure Mercy and Methodist both have anti-venom for potential snake bites. Yeah, I'm pretty sure they have to keep that there because of the zoo, or the zoo pays for that to be kept at the hospitals in case something ever happens. Again, if you're unsure, which I'll be honest, when it comes to poisonings or like a snake bite or something like that, or God, I can't even think, different spider bites. If I'm unsure, I'm calling the hospital. There's no shame in that. Hey, here's what's going on. Here's what the patient presents like. Here's what I'm seeing. What do you think? There's nothing wrong with that. Um, One thing we have to be cognizant of and be a little bit careful with is those suicidal patients or patients that might be in custody, especially if there's potential that they'd overdosed on something. I will tell you my protocols that I wrote. Somebody's threatened suicide, they don't get to refuse the hospital anymore. They've lost that right. And I give them the option, and I'm not there to fight with these people. I'm actually one of the most compassionate people when I talk to them, because I don't want to create a mountain out of a molehill. Is I say, hey, here's a couple options we have. One, you can ride with me. We can go to the hospital, get you checked out, get you, I'm sure, some counseling or something like that. You'll be back at home, no big deal. The other option is law enforcement takes you, and to do that, we might end up having to get a warrant. It's going to take a little bit more time. and their car isn't as comfortable as the back of an ambulance. And that's something absolutely I'm getting in contact with medical control about, especially if the patient is severely refusing. And it might be something that I think we're going to end up having to sedate the patient or chemically restrain them at some point. I try to get as many bases covered as possible before taking those routes. It's not always possible. I've had the patients that I've had to sedate really quickly because they were pretty violent, and then obviously called the hospital afterwards and let them know what was going on. But just be careful. Um, when you're talking to those people, treat them with respect. You don't know what somebody's going through in life. You don't know what kind of bad things somebody just had happen to them. You know, everybody thinks differently. Just be respectful of those people, especially if it's somebody in custody. They're already under arrest. They're already having a bad day. Don't walk in and be an ass to them. It's going to make things so much worse. If you can find out what was taken, sometimes that's not possible because sometimes they really just don't want to tell us. But if you can find out, great. What was it? How much did they take? How long ago did they take it? Have they taken it with anything, especially alcohol? I don't know why alcohol seems to be a great chaser for pills. And is this something that's commonly happened? You know, our elderly population that overdoses on accident on their blood pressure meds isn't necessarily intentional overdose, right? But there are the times where we have to consider that maybe it is potentially an overdose on purpose, but it's being played out to be an accident. So we kind of have to go with our gut instinct with that, and we kind of got to know some of these questions that you see here: what it was, how much, how long it's been, how often it's happened, and did they take it with anything? You know, the people that always kind of throw me off are the ones that, oh God, I don't know, take 30 aspirin mixed with 30 Ativan, mixed with this, mixed with that. Those are people that are legitly trying to accomplish a goal. And those are the ones we need to be really concerned about. And those are probably the patients I'm going to maybe transport a little bit quicker than the others. Especially with your physical exam, another thing that I like to look at is if I can see any previous attempts of suicide. And I hate to be that way, but it paints a picture in my mind of what is potentially going on. Just so, again, it covers my base if this patient is to refuse. I can use that as ammunition if I think they should have to go to the hospital, and either calling the hospital and speaking with a doc or talking with law enforcement or whatever it might be. But looking at your patient, you know, what do they look like? We're taught that all through paramedic school. What do they look like? Are they pale? Are they diaphoretic? What do their eyes look like? Are they sluggish to respond? Are they pinpoint? Checking somebody's eyes isn't necessarily gonna be one of the first things we do. You know, I'm not gonna run up to somebody, stick a flashlight in their face, and they're gonna be really happy about it. It's generally something you're gonna do a little bit later on once you're assessing them, once they're a little bit more comfortable with you, especially if there's a potential that they've taken too much of a substance. And what does their mouth look like? What do their lips look like? Does it look like there's any sort of burn? Does it look like, you know, they just ate powder or anything like that? Those are things that we should be looking for, especially when we're talking to these patients. Um, I'm not saying get up in their face or get up in their grill, but get close enough to where you can either smell or see something that is potentially um, an issue or potentially evidence that you can use to kind of help you with your differential diagnosis of these patients. Chest, I really don't think I look at the chest, to be honest, especially if it's a substance, unless it's some sort of absorption powder or something like that. Um, Checking their pulse is always a good thing, especially if it's a medication that could potentially have a impact on maybe their blood pressure. Maybe they overdosed again on their blood pressure meds or some sort of cardiac med. This is what I just talked about. Patients who essentially are polypharmacists, ingest more than one thing at a time. Again, those patients are on the track to accomplish a goal, and that goal might be suicide. So we have to take it with face value when we ask, "Hey, have you taken anything?" "Yep, I only took this." "Okay, why is there an empty bottle of something else over here?" "Oh, well, I don't know." Sometimes we kind of have to, and I hate to say this, pardon my French, we have to dig through the bullshit and try to figure out truly what's going on. If you think, again, that we need to take their airway quickly, then we need to take their airway quickly, just as long as you can justify it as to why you're doing it and what your reasoning for it is. Most poisonings or most overdoses or anything like that, generally I'm starting a lock, IV with a lock, just in case the patient does have any sort of reaction while I'm with them, or God forbid goes unresponsive or goes into cardiac arrest. Those patients as well should be on a cardiac monitor. I'm not necessarily saying a 12 lead. Maybe, I guess, if we're looking for electrolyte imbalances, but they should at the very least be on a 4 lead so we can look to see if there's any abnormalities. We shouldn't be giving sugar until we know they are sugarless, if that makes sense. Why give something that the patient doesn't need? You know, it's the same there. If suspected of a narcotic overdose or opioid overdose, give Narcan. Sure, I'd agree with that. Generally, in my opioid overdose patients, I give them enough Narcan just to get the respiratory system back, and I'm probably done giving Narcan at that point, just because I really don't want to fight them in the back of my enclosed ambulance. D50, those patients can come up swinging as well. Not so much a poisonous or substance problem, but maybe if they took too much insulin, I guess. This is pretty big, and this could be something that's national registry wise, to be honest. If chronic alcoholism is suspected, 100 milligrams of thiamine could possibly address any sort of issues. I will tell you, in chronic alcoholics, and you could have a question like this, like maybe the person's homeless, they're an alcoholic. What's a medication we consider? It's thiamine, vitamin B. That's, please, for the love of God, remember that. Vitamin B, thiamine for chronic alcoholics, just because it helps their body. After so long that alcohol takes an effect on their body, it limits the amount of B12 they have within them. They're malnourished. They're really skinny. They're really frail. Giving that thiamine, I don't know anybody that carries it, but for some reason it's a constant in our EMT question. Don't induce vomiting, for the love of God. Just because we don't know what the substance is, and if there's any chance that mixed with stomach acid or whatever coming back up could potentially harm the patient, such as airway burns or esophagus burns or anything like that, yeah, we don't really want to be doing that. I'm just trying to look through some of this stuff. Again, I talked about people huffing paint or any sort of even lighter fluid. Butane was a big thing for a while. Huffing reduces the amount of oxygen to their brain. Huffing itself doesn't kill brain cells. It's the lack of oxygen to the brain that kills brain cells. I can't imagine smelling something out of a spray paint can or whatever can it might be, Freon or whatever, and not having a reaction to it. But again, these are people that are desperate to get a high and maybe don't, have money to go out and buy some sort of street drug or something like that. So they turn to that. For a while, there was even an issue right here in Des Moines of people breaking people's AC lines on the outside of their home or cutting their AC lines or whatever, just to be able to steal Freon or huff off their AC unit.
Canned air.
Canned
air was a big thing too.
Yeah.
Canned air. Can you believe that?
I forgot about that. Keyboard cleaner, what I call it. That's another one. I don't understand how people do that. The funnest thing I've ever done with a can of air cleaner or whatever you want to call it is turned upside down to freeze things. That's the extent of it. But again, some people are so desperate to get a high that they go ahead and look at what substances could potentially do this. I don't know who in their right mind thought that was going to be a great idea when they first did it. Another thing as well is, oh God, I lost what I was going to say.
A lot of people use like the whipped cream. Instead of turning it upside down, you'll just suck on it. I promise I've never done it, but
whippets.
Suck on it. Yeah, the little whippets.
Yep. And again, I don't know who was the first person to think of that. I guess I don't, maybe my mind isn't built the same or to the same intelligence their level is, but I, I don't know why somebody would do that. Um, some of the common signs or symptoms we could potentially see central nervous system wise, pretty common: confusion, altered mental status, hallucinations is a big one, depending on what they inhaled. We could potentially see seizures, especially if there's any sort of reduced oxygen to the brain. The brain kind of freaks out, those neurons randomly start firing, patient goes into a seizure. Um, for the longest time, people that were huffing paint would go unresponsive right afterwards. Literally, they'd have some sort of almost like a what's the word I'm looking for? Decorticate posturing. They'd huff paint, their arms would kind of turn inwards, they'd almost like cramp up, and they'd literally like just fall over because they overwhelm their brain. They rob their brain of all the oxygen, and their brain is freaking out at that point. Terrifying to watch, to be honest. Obviously, cardiac arrhythmias is something terrifying as well. That's something we should be monitoring as paramedics. If we're not sure what a substance is, or we're not sure what could potentially be the issue, we need to be placing these patients on a cardiac monitor. We shouldn't be, just for any reason thinking, okay, I'm just going to drive this person in. I'm not really going to do much. They're fine. That's not how we should be functioning. We need to be monitoring these patients during transport. At the bottom there, that's our local poison control number that I put in here. Please, if you don't have it in your phone, make sure you get it in your phone. Best thing we can do management wise with the patient, remove them from the environment they're in. This could be something as simple as CO poisoning, getting them out of the house to fresh air, making sure that we're wearing the proper PPE to do so. If they have anything on their clothing, potentially cutting their clothing off, get it off of them. One of the worst things we can do is put saline or anything on top of a powder, because now we've actually spread it. We took it from what it was, introduced a liquid, and it's now easily more spreadable. And when in doubt, again, contact your poison control center and medical control if you're unsure. There's no shame in that. I don't understand some people that, don't want to call a hospital or anything like that because they think it makes them look like a bad medic or something like that. No, call the damn hospital. That's what it's there for. We're not doctors. We're not to a higher level of education like they are. If you're unsure, call the hospital. Again, best thing we can do for patients, get them out of the environment they're in, especially if it's a suspected poisoning. CO, we'll cover CO and then I'll give you guys a break. Is one of the biggest issues that we're going to come across. That's why, does anybody now, as it sits, does any of your first out bags have like a gas meter or anything on it by chance that you take, something you take into the house just on every call?
Yes.
Yep.
Now, and that's more common than anything now. And it happened to me once. It's only happened to me once. I wasn't thinking, patient called, they were the only one home, they were having a really severe headache. Me being me, I trot right in the house. I'm going to save the day. I usually kneel down when I'm talking to patients because I'm a little bit taller person. Person was sitting on the couch. I kneel down, and I heard this loud, obnoxious beeping, and I was like, "What is that?" And had no idea. And until I realized when I looked in my bag and the red light was going off on the meter, that this patient was experiencing a headache because of CO poisoning. Best thing I did for that patient at that time, let's get out of the house. Let's go ahead and get out of here. Guess what? In fresh air, their symptoms cleared up. Okay, no big deal. You're probably going to end up getting a refusal out of that patient. CO is really big in industrial areas as well, enclosed areas where there's a potential for CO exposure. Especially, and I hate to be this way, I hate talking about suicides or anything like that. Something to also consider is, the person that has their car running in their garage. It happens more common than you think, and a lot of times it's not even on purpose. It's really cold outside. They want to warm up their car in the garage before they pull it out. Don't open the garage door. They hit the remote start from inside their house. That's a concern. Because the second they open that door to go into their garage, they're overwhelmed with fumes and they're down. And from there, it's just going to get worse. Unless a neighbor or somebody hears an alarm going off. There was a book I'd read about, it followed a guy in his EMS career in St. Louis. And he talks about one of the summers that they had. It was extremely cold, or not summers, one of the winters they had. It was extremely cold. He talks about a house they went to for a welfare check. It was an elderly male and female. And he found them both deceased in their bed, unknown how long they'd been there. And it was due to CO poisoning. CO is deadly. It's odorless, it's tasteless. There's no way for us to know that there's truly CO. That's why we should be, especially if you work on a fire department. I hate to pick on people that work at a fire department, but one of my favorite things to do when I go on a medical call, I look where their CO detector is or where their smoke detector is, and I pull it off the wall and I look at it. What's the date on it, and should I change your batteries? I don't care if you work for a fire department or not, you work for an EMS agency. Ask them the same question. Hey, when's the last time you changed your batteries in your CO detector? Most people don't do that. It's not something that's commonly done. CO is very much like carbon dioxide, is that it binds to hemoglobin a lot easier than oxygen does. So remember, these are the patients. I put a pulse ox on them. I get a reading of 100%. I'm like, oh, you're golden. You're breathing better than I am. And they're really having trouble breathing and really lightheaded. Put them on end tidal. I'm guessing you're going to see a really increased end tidal reading because their pulse ox can read 100%. Yeah, their blood is saturated with 100% of something. It's not oxygen. Could be CO, could be carbon dioxide. Who knows? Best thing you can do to these patients, get them out of the environment. Get them into fresh air. I'm not saying strap oxygen on them right away. Get them outside at the very least. Get them out of where they're at. Always consider CO poisoning. If you work for a service that doesn't have a meter on one of your first out bags, something to talk to them about. They're super cheap and they can honestly save lives. CO poisoning, if left, once it progresses, obviously we can see some cardiac issues. You can start to see like some PVCs. You can start to see sinus tach, SVT. And then to the point that the CO poisoning is so severe, the patient will go severely bradycardic before they go into cardiac arrest, just because that CO has robbed all the oxygen out of their body, and their heart has no fuel to essentially be. Their brain has no fuel to essentially function. Can't tell its body what to do at that point. So you will start to see their body essentially shut down at that point. Boy, they really like hitting CO here.
It also causes seizures. We had a really bad CO call the other day.
What do you mind like talking about a little bit, like what you guys get dispatched out to, what all that?
Yeah, I actually got minor CO poisoning from it. It got dispatched out as a diabetic call in an altered mental status. And he was in the garage, but we really didn't think much of it. So we went to check his blood sugar, and it read 151. And it smelled like gas in there, but it smelled like he had just like spilled his gas can. Last time he was seen, it was like at 8. And we were starting to go through our assessment, and fire went out to grab their CO detector, and it was 5 times over the lethal limit. He had been in there since like noon at least. We got him loaded up. We called a helicopter, and we got him out to the hospital when he started seizing and everything. We ended up taking him down to Iowa City that day because we couldn't get a flight because of the rain.
Sure. And I've read about cases. We actually had one here in Des Moines when it came to CO poisoning. They'd found a gentleman deceased in his garage. They decided to open up the garage door because obviously their gas started alarming, or their gas meter, whatever it was. Opened up the garage door, went in, and were like, there's nothing. Like, they had the CO detector in the house, everything. They couldn't even find levels of CO anywhere. And they were like, well, maybe it wasn't a CO poisoning. But the neighbor thought they'd heard like the smoke alarms going off earlier in the day. So we're still kind of cautious. Ruled it out, said, it must have been something else. Maybe the guy had a heart attack or something like that. Well, his keys were in his ignition in the run position. Gas tank was empty. What happened, do you think? Car ran out of gas and shut off. Could that have caused CO poisoning? Sure. They opened up their door, they vented it, they got the CO out of there. The car had been running for a little while, so it's not constantly producing that CO. Absolutely.
Rudy, we had a call here a while back that ended up with 9 first responders transferred, first responders and law enforcement from CO poisoning.
Holy, where was that? Where's that at?
It was up in Wacoma is where the call was. So they got called out for, I forget what the original call was for. They coded a guy, and then first responders started getting sick afterwards.
That's, dude, CO's not. I'm telling you, I wasn't a believer until getting, because I'm a guy that has a budget to deal with. I wasn't convinced on getting a meter for a bag until I was the one that the meter went off on. And I would have never known, had I not had that meter on my bag, what was going on.
My first responder agency that I'm on is the only department in the county that carried CO detectors until then, and I think most of them haven't ordered since that incident.
Yeah. It, unfortunately, in fire and EMS, and God, please, this might be my own opinion, we're very reactive when it comes to things. It takes something bad happening before we change something, unfortunately. Common signs, symptoms, nervous system wise of CO poisoning, your headaches, dizziness, confusion, seizures. There you go. Ultimately, coma that will lead to death if left untreated. All right, let's take a 10-minute break. We'll come back at 7, and we'll keep going through this. I actually have another story to tell you guys when we get back from break.
Hey, Rudy.
Yeah.
Hey, can you reshare your screen or something? My internet dropped out and I've not been able to see your screen for about 20 minutes.
Okay, yeah, I'll exit out and get back in. Is that any better, Kyle? Can you see it now?
Perfect. Thank you.
Yep.
Yeah. So, and no one.
Give me 1 second, guys. Sorry about that. I had a problem with the computer and had to call our IT guy to get my computer fixed. All right. So, one of the things that I wanted to bring up that I mentioned before break isn't so much a story, but something to watch out for as well. And it doesn't really happen a whole lot anymore, but when we talk about suicides or stuff like that, is the potential for somebody to commit some sort of chemical suicide in their vehicle. And then, somebody sees them slumped over in their car. They call, we rush up there, we open the car door, whatever that chemical was is now moving on to us. Be careful about that. One of the things I always try to do, and I don't, maybe it's happened once or twice where I've been doing unresponsive person in the car, is I try to look in the back seat before I open the door or look for any signs that kind of make me nervous or anything leaking out of the car or anything like that. So just be really cognizant of that as well. I'm not going to beat a dead horse with CO poisoning. I'll just tell you, treatment wise, we should test question wise, even national registry wise, they're not going to throw a whole lot of CO questions at you. It might be identifying, signs and symptoms. Maybe there's 5 people in the same household that are developing the same symptoms. There's 2 possibilities. They either all ate the same thing or it's CO poisoning. Those are the only 2 things it's going to be. They either came in contact with the same thing or they ate the same thing. That's 100% what it'll be every single time. The National Registry isn't trying to trick you. They're trying to figure out your base knowledge. They're trying to figure out if you have enough knowledge to be a foundational paramedic. And what I mean by that is, can you determine the difference between CO poisoning and, let's just say, asthma or an allergic reaction? It will not be a fine line of, okay, they have a headache, they're dizzy, their blood sugar is 25. Do you think it's CO poisoning? Probably not. It's probably a blood sugar problem. They won't give you, okay, person's complaining of a headache. What do you think's wrong? That's too open of a statement. They will narrow it down a whole lot for you in the scenario. Just like if we over-oxygenate our patients, CO can do the same thing. It creates what's called free radicals. Problem is those free radicals are actually harmful for the body. That's why in cardiac patients we say don't go above that 94, 99% as far as oxygen goes. If they're fine at 94%, leave them there, because introducing more oxygen makes the heart work harder. Same thing with CO. It's going to make the heart beat faster, make the heart want to pump faster, when that's not necessarily what the heart needs when it's already struggling due to lack of oxygen. CO poisoning, persons at risk, obviously the extremely young, extremely old, just for the simple fact that extremely young might not be able to either get out of a residence or identify what the beeping is. Same with elderly people. Maybe they're hard of hearing. People with diminished lung capacity, such as COPDers, patients with emphysema, patients with whatever it might, bronchitis, whatever it might be, chronic bronchitis. Those people are more at risk just because they don't have the lung volume or residual capacity to deal with any sort of CO poisoning, because it starts to wreak havoc on the lungs before anything else. Often misdiagnosed. That's why I said they won't throw a whole lot of national registry questions at you. with limited information, because it is very common to mistake something else for CO unless you are truly, you have a meter or you have almost like a CO. I want to call it a pulse ox. It looks very much like a pulse ox, but it determines CO within somebody's body. Or they can breathe through a meter as well to determine their CO level within their lungs. But really, those patients need labs drawn, they need blood gases to see how much havoc that CO has wreaked. What has it done to their acid-base balance? Generally, when you get these patients into an open, fresh air situation, their symptoms are going to start to diminish. We just want to make sure we're doing that in an effective time frame if we suspect CO poisoning is really an issue. Cold of winter, CO is always on my mind when I go to somebody's house with a headache. Not too often I have somebody call with just a headache, but that's always something I'm thinking of. I'm making sure that either that meter is strapped to my bag, which it is, it's strapped to one of the straps on the bag, or I literally put it on my coat. So that way I know where it's at. And if it starts alarming, it's right there by my face and I know what's going on. Different categories for CO poisoning: suspected. So you think the CO might be the issue, but you can't really confirm that. Probable, there is evidence that indicates that it might be a CO issue, and then confirmed would be like your meter going off. So confirmation that there is high levels of CO within a residence or within a contained area or enclosed structure. When it comes to a lot of poisonings, what you guys will notice is we're treating the patient. We're treating their symptoms. We can't necessarily treat what's going on. I don't have an antidote for mushrooms. I don't have an antidote for venom. I don't have an antidote for black widow bites. I don't have an antidote for CO. I'm treating what their symptoms is presenting as. It's weird because I've been saying this whole year, treat your patient, not the monitor. That's what our end goal should be. Patient's fine, bring them to the hospital. Monitor them on the way to the hospital. Start an IV so you have it. Put them on a cardiac monitor. Put them on oxygen if it makes them feel better, because I'm not worried about any cardiac problems at that point. So I'm not worried about giving them too much oxygen. If it helps them breathe better, their peace of mind, whatever. Also consider that if this was in somebody's house and their CO alarms are going off, they might have anxiety as well. Numbness, tingling in their arms and legs because they're hyperventilating. Might not be a CO problem, might be just they're anxious of the situation itself. Always take that into account, is that when somebody's calling 911, they're not generally relaxed about it. Usually they're a little bit fearful of what's happening. HBO, not the TV series. It generally stands for hyperbaric oxygen. Facilities that have hyperbaric chambers for people that have severe CO poisoning or even hydrogen cyanide poisoning or just cyanide. Really, a hyperbaric chamber is essentially creating pressure to hold their lungs open, kind of like CPAP, but it's enclosed, and really makes it a lot easier for them to breathe, creates that negative pressure, creates positive pressure. There is no proven evidence that hyperbaric chambers honestly improve prognosis of patients, I will say. There's certain criteria that meets it. I will tell you, in our region, in our areas, I don't think, I'm taking the patient straight to a large facility, Mercy, Methodist, whatever it might be. Maybe if you're in one of the critical outlying areas, you're probably gonna bring them downtown as well. And they'll probably stabilize them and then transfer them. If they think a hyperbaric chamber is gonna work, if they don't have one at the facility, they'll transfer them somewhere that does have one at that point, once they get them stabilized. There's your hyperbaric chamber right there. Again, CO poisoning, it's essentially a pressurized chamber that it makes it easier for the patients to breathe. Patients with significant cardiac compromise, this generally isn't the best thing because it's putting pressure on them, and their heart might not be able to handle that pressure and might actually start to begin to shut down. Again, there's no, and I hate saying that, but there is no evidence that hyperbaric chambers are truly working with these patients. As far as monitoring them, end tidal, pulse ox. I'm not even, I maybe you can go as far as say 12 lead just to see if there's any abnormalities. 4 lead at the very least, and just get them to their facility. I mean, treat your patient, treat what they're presenting with, treat what they're complaining of. Cyanide, again, product of combustion. Plastics. Everything in our house is made of plastic anymore. Your couches are plastic. Your countertops, your desks, your mattresses. They're all things that produce toxins when they start to burn. That's the same reason houses now burn 50 times faster than they did in the 60s and 70s. Is because all the materials that things are made of. A couch used to be made of heavy wood, or timber, or whatever it might have been. Same with houses. The problem is we've now gotten into the age of we can produce this for less because we're using a different type of material. The problem is when things go south with that material, it off gases something such as cyanide. Colorless, might potentially give off a bitter almond smell. I actually went to a class out of state on actually through TEACS on kind of similar to weapons of mass destruction. And one of the guys that taught the class was fire chief for the Phoenix Fire Department, and he was talking about cyanide poisoning. And one thing that I'll never forget he said is the times that we've had to deal with cyanide or something like that, I've never smelled an almond smell. It's obviously a key diagnostic that kind of, is a key characteristic. So if that's something that comes up on a test, almond smelling, I would probably lean towards cyanide. Obviously can be a weapon used against a population as well. Most commonly, where we're seeing it is either patients that were residents inside of a house that had caught fire. Maybe they were in there too long. They essentially get cyanide inhalation. Same with first responders, maybe firefighters, whatever it might be. Could potentially get that cyanide poisoning. That's where we're most often seeing this potentially happen. Key characteristics as far as signs and symptoms go: burning sensation, mouth and throat. The problem is that could also be a number of other things. Headache, confusion, combative behavior, same thing. Seizures, coma, pulmonary edema. Why do they have pulmonary edema? Well, it's because their lungs are injured. When something is injured, naturally it I don't want to say off gases. It has its own products of elimination, if you will. Kind of like if you get a small cut on your finger, what happens? It bleeds. What happens if you get sunburnt? You get blisters. What happens if those blisters pop? They have liquid in them. When our lungs get injured, they can also develop liquid in them. That's why we develop this pulmonary edema. As far as determining if it's cyanide or not, we have no definitive way to determine it's cyanide unless for some reason we have a confirmation that that's what's being used. Best thing that I can tell you with treatment wise, get the patient away from whatever the source is, get them into fresh air, making sure you're watching over yourself. They do have what's called cyano kits, CYANO kit, and it's essentially two medications, kind of like 2-PAM, that is an antidote to be able to reverse cyanide poisoning, or not so much reverse, but assist with the treatment of cyanide poisoning. There's what your kit contains: your amyl nitrile capsules, nitrite, sodium nitrite, and then sodium thiosulfate solution. I don't know anybody that carries cyano kits, to be honest, unless you are in a metro agency that much bigger than even Des Moines or Cedar Rapids, that has a dedicated, special response team to chemical agents. And I'm not talking just a hazmat team; it'd be just a specialized team. They might carry those, or like military bases or something like that, areas where we have a high risk for some sort of attack potentially as well. I would probably know what the cyanode kit is and what's in it. That's why it's highlighted.
Cedar Rapids Fire carries cyanide kits.
Do they?
They only have two. It's in their battalion chief trucks.
I think you told me that at one time. Now that you said that, I don't know, and that's something I should reach out to Des Moines tomorrow and ask them as well. I don't know anybody else that really carries them, but then again, I've never really asked anybody if they carry cyano kits. You would think most fire agencies would, for the simple fact that we are exposed to it in most house fires. But again, I'm not sure what the cost is behind it or anything of the sort, to be honest. So that's something I might look into, to be honest. This is huge, especially in our elderly population. And when we went through cardiology, you guys have heard me tell the story about the patient that I had that overdosed on metoprolol, severely bradycardic. We ended up pacing her just because she had accidentally overdosed on a beta blocker. In our elderly populations, it might come down to you counting pills. Seriously, if you're not sure what's wrong, and there's a potential that a medication is the issue, yeah, you might be counting pills. I hate to say that. Yeah, it takes time. Yeah, it's kind of tedious, but if that's what it takes to figure out what's going on with your patient, that's what you might have to do. Some of our concerns is into any antiarrhythmics. Maybe they're prescribed amiodarone or cortisone. Beta blockers such as metoprolol or anything that ends in lol, those are beta blockers. Calcium channel blockers, ACE inhibitors. So really anything that can affect cardiac function. If somebody overdoses on it, obviously cardiac function is probably going to be decreased at that point. Big thing to watch out for cardiac medications. Look for responsiveness within these patients. Hemodynamic stability, so what's their blood pressure? And cardiac monitoring. What do you notice about their 12 lead or their 4 lead? These patients, if it's an overdose of a cardiac med, they need a 12 lead. You can't get by with a 4 lead on them. Be prepared to treat maybe a slow rhythm or a fast rhythm, depending on what they potentially overdosed on. That's a good thing about overdosing on cardiac meds, is that we generally have other meds to try and fight the symptoms or the signs of it, but who knows how much they took of a substance. Anybody, reversal agent for beta blockers? Anybody remember? One person? Maybe?
Glucagon?
It is glucagon. Good job. But again, a lot of services are kind of getting away from carrying glucagon because it's $450 for one dose. In my instance, this is exactly what happened to me. My patient overdosed on metoprolol, severe bradycardia. I think her heart rate was 27, if I remember right. Atropine didn't work because she had developed a heart block. So we went right to pacing right off the bat. I went to pacing without even considering atropine just because she was unstable. Remember, stable patients get medications, unstable get electricity. Calcium for calcium channel blockers, weird. Glucagon for beta blockers. I don't know anybody that carries anything for digitalis or digoxin overdoses, to be honest. Your biggest ones you're going to see is calcium or glucagon. And does anybody service that I know of carry calcium? Or calcium chloride or anything?
Mitchell County does.
Really don't. Who does? Did you say?
Mitchell County.
Okay. Yeah, and it's few and far between. Whether they're carrying it out. You'll see it more often in like critical care or IFT settings, where they might have to give the patient a calcium bag or something like that, but it's not very commonly carried in like your 911 response agencies. Caustic substances, anything such as an acid. Battery acid was a big thing when I worked in the shop. Either in a powder form due to like a battery maybe bubbling over, or battery acid straight was always a concern. Anything that is an alkali or an acid, remember the difference. Acid is anything below 7.35. Base is anything above 7.45. Both can be potentially harmful, especially if ingested. But just remember your acid versus base. Acid is below 7.35. Base is above 7.45. Issue, result, tissue coagulation and necrosis. When we think of D50, and I know I brought this one up a lot, D50 is very acidic. I think its pH is 4.2. That's why we always say if you blow a vein giving D50, notify the hospital because it can tear away at the person's tissue. and tear away at their blood vessels because it's very acidic. Obviously, with those acids, we're looking for burns, right? Burns around their mouth, potential airway burns. Their tongue will be a really big indicator as well. And it's not just a normal burn like blackened or charred or anything like that. A lot of times it's a chemical burn, so it might appear white and charry at the same point. Any potential for airway compromise, we need to be taking their airway from them. Something that I don't carry Drano in my house or liquid plumber. I guess I don't have a need for it. But that is obviously a concern because it is a very strong alkalytic agent, pH greater than 12.5. The problem is if ingested, you'll see some of those signs down there. Perforation of the bowels, internal bleeding, because again, it's eating at the lining of their intestines or eating at the lining of their stomach, whatever it might be. They're essentially getting tissue necrosis from the inside out at that point. Best thing, the only thing I can think of treatment wise that they're going to do for these people is maybe activate charcoal right away to bind to it, and then possibly looking at pumping your stomach or whatever it is, maybe inducing some sort of diuretic or diarrhea inducing agent to flush whatever it is out of their system as well. Rapid transport with these patients, to be honest. There's nothing more than treating their symptoms that we're going to do for them. Treatment and things that we're going to be looking for is literally 90% of it is going to be upper airway. You know, facial burns. Okay, facial burns are an indication that we probably have airway burns. Lips, throat, tongue, gums. Okay, mouth, right? Go leads to the airway. Drooling, trouble swallowing. Very much like epiglottitis. That's a concern for us. Maybe that's a swollen epiglottis. Maybe we have, we're starting to get swelling around the trachea. Very big concern. Hoarseness, stridor, shortness of breath. 4 of those bullet points are all airway related. 1 is shock from bleeding or vomiting. Rapid transport with these patients. I cannot say it enough. Rapid interventions. If you need to take their airway, remember there's that line in the sand. At what point do I take their airway? If the thought crosses your mind of, God, should I do it? You probably should. But again, just make sure you can justify it. Hydrocarbons, this is going to be like your lighter fluids, butane, solvents, maybe like paint thinners. Again, these are most common is going to be inhalation due to patients looking to get a high of some sort. Very much same symptoms. You're going to see that throughout this whole chapter until we get to like spider bites and plants and stuff like that, which is a little more interesting. Foot and wrist drop, numbness, tingling. If you notice, how many of these signs and symptoms mimic a stroke? Slurred speech, foot and wrist drop, numbness, tingling. This patient very much could present like a stroke patient, right? That's why it's important, our assessment. What questions are we asking? Less than 1% require physician intervention. That's because usually this isn't a huge deal. Usually they're not inhaling enough to cause these severe side effects. Generally, you'll start to see the side effects subside as soon as they're away from the chemical agent. Getting them into fresh air is the best thing you can do for them. TCAAs, tricyclic antidepressants. We're starting to get into some of our overdose meds. Treat depression, treat anxiety, very common in society. Not so much TCAAs, but medications for antidepressants or whatever it might be. I will tell you when it comes to TCAAs and testing wise, and when I say testing wise, I'm always referring to the National Registry. One of the things they will always say to consider if there's a TCAA overdose and the patient's having severe signs and symptoms is to give sodium bicarb. Sodium bicarb actually will bind with the acid that is caused by the overdose of tricyclic antidepressants and begin to lower that pH back down to normal. Because once they overdose on TCAAs, our concern is now our pH is out of whack. TCAAs, anything that ends in lean, peen, mean, amlodipine, amitriptyline, all very common TCAA medications. Anything that ends in those LINE, PINE, MINE, INE, really. I'm not saying remember it's TCAAs. You might, sure, but categorized, it's going to be an antidepressant of some sort. You're not truly going to know they've overdosed on TCAA unless you identify the medication. And again, I told the group today, I can't look at a medication, and honestly, I didn't remember the root of the word here until I was going through this PowerPoint, and I was like, oh yeah, I kind of forgot about that. If I'm not sure what a medication is, guess what? I Google it. I look it up. That's perfectly fine. Pretty late signs of an overdose with this: confusion, respiratory depression is pretty common because, again, it is an antidepressant, can cause the patient to become very overly tired as well as cardiac arrhythmias. We should be monitoring these patients with a cardiac monitor. If severe enough, consider sodium bicarb to treat it. If you don't have a protocol for it, maybe that's something you call medical direction for if your service, allows medical direction to override what your protocols are. Because it's still within our scope of practice. It's still a medication that we can give. It's common in some other services. Like I know my service, we carry bicarb for TCAA overdoses. So you're not wrong to contact medical control about it. MAOIs, again, we're getting into this, antidepressants, very common in younger populations. I'd say 13 to 20s roughly of younger population using them to overdose on, just to, I don't want to say purposefully overdose or purposely commit suicide, more not statistically, and again, this is numbers, this is my opinion, it's due to something that happened at school, maybe a boyfriend or girlfriend broke up with them, they kind of want attention, what's going on, so they take too much of their medication. Generally, it's not a massively huge deal, and these are the patients that I am calling medical control on, like, hey, they took too much of their Zoloft, what can I expect to see? Do I need to bring them into the hospital? What's your recommendation? One of the first things they're always going to ask, how much of it did they take and how long ago was it? And that's one of the questions we should be asking the patient prior to calling. You want to have all that information before calling medical control. But the times that I have called in, I'd say 9 times out of 10, doctor's been like, hey, they don't need to come to the hospital. Just have the parents monitor them at home. If it was a suicide attempt, that's a different story. If it was an accidental overdose, yeah, parents can monitor them. They purposely did it for suicide. We kind of get into a gray area there. We can't force them to go since they're a minor. That's where parents really have to make that decision. A lot of these, no antidote exists because we're treating the symptoms. If vasopressor is needed, okay. If seizures, we know how to treat seizures, right? We know how to raise blood pressure. We give fluid. We give medications to raise blood pressure. Treat what's going on with your patient. I have somebody that overdosed on Zoloft and they're having a seizure. Guess what? I'm not treating the Zoloft overdose. I'm treating the seizure. The Zoloft overdose can be fixed at the hospital. I need to treat what's right in front of me at the time. Some of the more common ones that we'll see, trazodone is really common. Wellbutrine's common. Prozac, a little bit higher strength. Zoloft is super common. Escitalopram is another one that's really common as well. Just be cautious. A lot of times when people accidentally either take too much of this or maybe overdose on it purposefully, the number one thing you're going to see is drowsiness. It's going to make them super, super tired, and they're probably going to sleep for an extended period of time. Very similar to if I have a patient that takes too much Benadryl. I'm not freaking out when it happens. Yeah, it's a concern. You took a whole bottle of Benadryl, but you're probably going to sleep for 3 days. Just a heads up. SSRIs obviously are going to release serotonin. What serotonin does within our nervous system is it creates a euphoric feeling, almost like a happy feeling. If we take too much of that, we get that excess of serotonin, and our body kind of freaks out a little bit, goes into freak mode because it's not sure what's going on. It's dumped all of its stores. It uses all of its energy up, and that's when our patients start to become drowsy. Some of the things we could see: tachycardia, drowsiness. I can't preach that enough. Maybe some seizure-like activity. Big thing to note here as well: signs and symptoms develop pretty rapidly with these patients. I can't, and I'll keep saying it through every slide. Treat the patient. Treat what signs and symptoms you see, please. Hypertension, tachycardia. Okay, I'm not going to treat tachycardia that's induced by medication. Hypertension, same thing, maybe. Excited delirium. If you have Versed, if you have ketamine, you might need to use it on those patients if they're in an excited delirium sort of state. But I'm treating the patient. I'm treating what the patient's presenting with. I'm not saying, hey, you overdosed on too much Prozac, I'm going to automatically give you Versed because I think you're going to have a seizure. That's not how this works. We treat based off of what we're seeing with the patients, based off of the symptoms that they are exhibiting at that point. Lithium, very common with bipolar disorder, or even schizophrenic patients or multiple personality disorder. You don't see it. I honestly have never seen it on a patient. And again, that's just me. I'm not saying, maybe I just haven't dealt with enough psychiatric patients to see lithium. Lithium can, if overdosed, cause almost like a dystonic reaction. So where we get that locking of the jaw or that constant moving back and forth of the jaw, twitching, increased reflexes, confusion. Again, these are all signs and symptoms that could be to multiple medications. How are we going to know? We're going to question them. We're going to look for pill bottles. They have a history of depression. I'm guessing they're probably, if we're worried about an overdose, maybe it was a depression medication. These are things we should be figuring out. If we're not sure, if we can't figure it out, they won't tell us. Transport them to the hospital. Treat their symptoms. These, believe it or not, are actually kind of serious. Salicylates such as aspirin, especially a concern with aspirin is not so much thinning out the blood, but creating it to where your blood isn't going to clot if you take too much of it. I was unfortunate when we get to the point of medications, and this is very similar to what I'm going to tell you guys. Hyperthermia, so they could develop a temperature, they could become a little lethargic, abdominal pain, vomiting, respiratory distress. Your body is not meant to have that much medication, right? The same for Tylenol and the same for ibuprofen. Trying to think here. Hey, Shane, are you on here? Maybe not. I was going to ask him if he remembered something that happened to me. I actually worked with him at the time that this happened.
Is that ready?
Do you remember when I was working at the airport and I had those really bad dental problems and I kept that giant bottle of ibuprofen in my locker?
Yeah.
What ended up happening to me? Do you remember?
You got in the hospital.
Yeah. I was in the hospital for a while. I had gone into essentially, my liver had began shutting down due to taking too much Tylenol and ibuprofen. I had developed a really high temperature. I, had started to become lethargic. I was really pale in color. I'd started to jaundice at some point. I was in the hospital for, I want to say it was a week. My body was doing some pretty crazy things as far as over-the-counter medications. And it was because I had dental pain. It wasn't me intentionally overdosing or anything like that. my body had built up a tolerance to ibuprofen, so I was constantly upping how much I was taking during the day to deal with the pain. What happened over a 6-month time frame is that it started to wreak havoc on my liver and my kidneys. By the time my wife took me to the hospital, I was having severe abdominal pain, severe lower back pain because my liver and my kidneys. I didn't know that's what it was at the time. I had a really high fever. The hospital didn't even know at the time because when I went to triage, they gave me Tylenol to break my fever. Problem was, I'd been taking a crap load of Tylenol, so it didn't really help. Again, I ended up on the floor at Methodist for about a week. It was probably one of the most terrifying things I've gone through because again, I could watch my skin start to change color. The whites of my eyes had started to jaundice because my liver was being attacked. Even to this day, I still have really elevated liver enzymes due to a decision of thinking I could treat myself because I'm too scared to go to the dentist. If somebody overdoses on ibuprofen, Tylenol, aspirin, whatever it might be, it's a concern. Just because it's an over-the-counter medication doesn't mean that they can't get hurt from it.
So,
It's
Rudy,
still
you're
something-
past. Sorry, you were past acetylcholine administration for overdosing at that point, right?
Oh, I'd been doing it for like 6 months.
Oh, okay.
I was past any sort of, and that's when when I go into the hospital, I had no idea again what it was that it caused it. And even to this day, I won't take ibuprofen now. I won't take Tylenol. If I have a severe headache, I'll fight through it. I won't take because I'm too scared of what my liver. There's our Tylenol. Obviously, we use it to treat fever, pain. Believe it or not, we can give Tylenol in the paramedic scope of practice, just nobody carries it. It is metabolized in the liver. Severe overdoses of Tylenol can create liver issues. And again, to this day, I still have elevated liver enzymes. I have to go every 3 to 6 months to have my blood drawn just to see if my LFTs or liver function test has come back normal at all. Signs and symptoms. I'm not saying you need to remember these stages.
Ready?
Yeah. You there? Hello? Can anybody hear me?
Yes.
Yeah.
I thought somebody said my name. I swear to God, somebody did. Anyway, I'm not saying remember these 4 stages to a T. Just know that as it progresses and it's left untreated, you will start to see their organs start to break down, such as, their liver starting to develop, their liver starting to break down, them starting to jaundice. And again, some questions, I gave myself as a scenario to the students today, some questions that I'd be asking are, okay, you said you were having severe dental pain. Were you taking anything for the pain? I mean, think if I had called 911 for abdominal pain. Would Tylenol and ibuprofen been the first thing you went to? No. What does the pain feel like? Dull cramping like? Okay, now I'm starting to think digestive system. Are you constipated? Have you had any bowel movements? No. Do you take any medications? Well, I take a Tylenol and ibuprofen. That raises a red flag to me. Okay, what do you take that for? The dental pain. Okay, how long has this dental pain been going on? Oh, about 6 months. How much do you take a day of that? I was taking 750 milligrams of Tylenol a day and 1,000 milligrams of ibuprofen. That is a crap ton of medication. I wasn't even thinking at the time of what it could potentially do to my body. Questions we should be asking patients if we're not sure. If you can, time of ingestion is great if you think it's an acute issue, such as a medication like, I don't know, an opioid or something like that. But in my case, I'd been ingesting it for 6 months. Is the time going to matter at that point? Not really. EMS wise, there's nothing they would have done for me. Maybe treated my abdominal pain. That's about it. NSAIDs, very much similar. Abdominal pain, swelling, drowsiness. rash, itching. It really depends. Here's the thing: anything can cause any signs and symptoms. Have you ever heard an infomercial for a medication on the TV, and the signs and symptoms are way worse than what you're treating? Blows my mind. Any sort of metals, we could potentially, lead poisoning, mercury, like from thermometers, or even if you work around any shipping facilities, like I know at the airport, we had an issue with mercury there at the UPS facility because they ship items, large items, and they had a mercury spill. That's a concern, especially if some patients start exhibiting signs and symptoms of a potential issue. I would want to know what that chemical is. Iron, and this could be as simple as taking too much of a supplement, causing, what iron's going to do is it's really going to wreak havoc on our intestines, bigger than anything. The problem with that is if we start to develop a GI bleed, we need to think back to your EMT days. Upper GI bleeds will present as dark tartar stool. Lower GI bleeds will present as more of a brighter red bloody because it's not passing through so much area. So just something to consider. A lot of these medications, liver failures is common with them. Lead, we've kind of got away from lead-based paint. It was a big concern, obviously, for a while, especially if you were working in any sort of industry that was maybe demolishing houses or redoing houses, or maybe you were, remodeling your house yourself or something like that. Yeah, it'd be a little bit more of a concern. Mercury, the big thing with it is thermometers. I can't say I've ever had any other instances with mercury or where I was concerned about it. I'll be honest, as a paramedic, I wouldn't even begin to know how to treat that or what I would have to do. That's one of those cases where I'm calling medical control. Hey, patient has a giant thermometer in their house. It fell, broke. They got mercury splattered on them. They're kind of they're having some trouble breathing. They're they've got a really high temp. I'm making up stuff. They're drowsy. They got a headache. I'm guaranteeing the doctor's going to say, okay, treat what you see and bring them to the hospital. Treat their breathing problems. Treat their headaches. Treat their pain. We can treat all that stuff. Look, very similar to any of the things we've been going over: headache, irritability, confusion, coma, tremor, weakness, agitation, abdominal pain, memory disturbance. I've noticed everything we've covered, it has said activated charcoal will not bind, like the last 6 things we've covered. Food is huge. And I'm not talking about just contaminated food poisoning. And this should be, I don't want to say pretty simple to figure out. Maybe it's a patient ate somewhere new. Maybe they ate something new. Maybe they ate at the one I always use is, a Japanese steakhouse or a sushi house or something like that. Yeah, it could be potentially a concern. How was the food handled? This could be at their house as well. You got to think salmonella. You got to think botulism. All these different types of bacteria that essentially can wreak havoc on our bodies just because of ill-prepared food. Common signs and symptoms of even, food poisoning: nausea, vomiting, abdominal pain. Generally, I'd say 2 to 4 days. The biggest thing with these patients is they become severely dehydrated due to that diarrhea and that vomiting. So a lot of our treatment is going to be based around administering fluids to these patients. Seafood. I get nervous around seafood. I don't think anybody's going to serve us a poisonous fish. I hope not. God, I hope not. But was it, I hate to say like a bad batch. Was it ill prepared? Was it underprepared? Some fish, obviously, you can have sushi, not a huge deal. But how were these fish? And I'm getting way too far into it. How were they raised? Where were they at? Is it in an area where there was disease? There was famine? Those all kind of come into play. generally these patients are just going to be your standard gastro symptoms is what you're going to see. To go as far as respiratory rest, I can't say that. Sure, that's what the textbook's saying, but there's some stuff I don't agree with on the textbook as it goes. Paralytic shellfish, I'm not even going to try to speak on that because I don't know a whole lot about paralytic shellfish. I'm not going to lie to you guys. I'm not going to beat the dead horse with the seafood either. Consider administration of antihistamines and antiemetics. Antihistamines such as Benadryl, if we think this patient is experiencing some sort of allergic reaction. Anaphylaxis, we might go as far as epi. And antiemetics such as Zofran to prevent any vomiting. Even if the patient's nauseous, give Zofran. Helps them out, even if it's a placebo effect. Zofran is one of the drugs I feel like we don't give enough. I think everybody should get Zofran. Everybody has a headache riding in the back of an ambulance, riding backwards in the back of an ambulance. Everybody gets nauseous riding in the back of an ambulance. If they're nauseous, give them Zofran. Be proactive. Poisonous plants, mushrooms. Again, in our area, we don't really have a whole lot of these. If you're not sure what it is, try to describe it to poison control. The colors, the shape of the leaves, what the patient says it is. Sure, if you're walking around some rural parts of Iowa, I'm sure you can find some sort of poisonous plant that you're going to run into. I'm sure you're going to run into some sort of poisonous mushroom. There's a difference between morel mushrooms and poisonous mushrooms. When I think of a poisonous mushroom, I think of something out of Mario Kart, that big bright red mushroom, as opposed to like a morel, which we're all commonly, that spongy-like appearance. One thing that will come up national registry-wise is muscarinic. If you see the term muscarinic, they're referring to poisonous mushrooms, and it is toxic to people, but they won't say mushrooms. They'll just say that muscarinic. So just a heads up that's usually having to do with mushrooms. There's our example of my Mario Kart mushroom or Super Mario Brothers mushroom, like that's literally what I remember from playing Super Mario Brothers as a child. Nintendo is those mushrooms that Mario would run and jump on to get a spring. Again, I'm not eating that. I don't know if other people look at that and think that's appetizing. I'm not picking that up off the ground to eat it. Biggest thing as well, especially if the patient is in a dangerous area, making sure you're keeping yourself safe for the love of God. I told you guys a story about me getting stung by a horde of yellow jackets. First thing I do was take off running, right? I remove myself from the situation. If somebody tells me, calls 911, hey, this guy's being stung by, he dropped the crate full of honeybees, I'm not rushing in there to figure out what's going on, because I can tell you I'm not going to handle the stings well. If you can identify what stung them, that might help out a little bit, especially for if they have to get any sort of antidote or treatment wise. Against snakes, I'm color deficient. I'm not very good with colors. I can't identify colors the best. I can tell, normal colors: yellow, orange, red, green, blue, indigo, violet, Roy G. Biv, whatever it was. If you can identify it, great. Somebody told me a story today. I can't remember who it was. Sarah, was it you that was talking about somebody pulling a snake out of their pocket? Or were you in there when that happened?
Nope, it wasn't me.
Okay. I didn't think it was, but I just want to make sure there wasn't a witness. I don't know if they were doing a clinical or I can't remember what it was. A guy got bitten by a snake. They asked if he knew what kind of snake it was, and he pulled the snake out of his pocket. I'm not saying go that far, but if you can figure out what it is, might help out a little bit to determine if it's truly poisonous or not. Any sort of bites, any sort of stings, obviously, we're watching for anaphylactic reactions. We're looking for those signs of severe allergic reactions: airway swelling, hives, airway compromise, the trouble swallowing. If you need help identifying something, call poison control. They're not just for poisons. They do plants, they do insects, they do snakes. Again, there's that word, bites and stings. anything that can sting or bite, Hymenoptera is the word that we are looking for. If for some reason somebody is stung and the stinger is still in place, such as, a honeybee, as you see there, they live with stingers most of the time. Don't try to pull it out with tweezers. Don't try to pick it out with your fingers. Best way if you need to remove it is with a credit card. Any sort of card you got that's slim, and just run it across the top of it, hoping you catch it and pull it out of its place. Generally, the swelling is still being caused by the venom on that stinger and the reaction, so that's why we want to remove that stinger if possible. I can tell you one of the most painful things I did as a child. We lived in Oklahoma. We just moved there. I didn't know what a fire ant was. I had no idea. And I sat down on a fire ant hill. After about a minute of realizing that you feel like your legs and your butt and everything's on fire, you realize really quickly that there's ants everywhere. Insect bites, one specifically, I don't know if they're going to cover it, is ticks, especially if we're talking Lyme disease. When we talk about Lyme disease, and this could be a national registry question as well, you get that like Target appearance. It literally looks like a Target, like the Target store, like their sign, the red circles. That's what it's going to look like with Lyme disease. Ticks are obviously a concern in Iowa because they're everywhere. Insect bites, you're going to get redness around the area. A really good indicator that it was an insect bite generally is 2 puncture marks. Commonly, people get bit by spiders in their sleep. I know that, recently within the last 3 weeks, I got bit by something while I was sleeping because I developed a little red lump on my arm and it had 2 holes in the center of it. Do I know what it was? No. Am I scared? A little bit. But it's identifying just based off of the appearance. Here you go. Scrape without a credit card, or scrape with a credit card. We don't want to squeeze. We don't want to pull because we might push it in further for any sort of stings. To wash the area, irrigate the area, use saline. Not a big deal. Use distilled water, whatever you carry in the back of your ambulance. Not a big deal. Ice packs to reduce swelling. If it's kids, it is the end of the world if they've got stung by a bee. I can tell you now as well, I'm not a big person that likes getting stung by things. My most recent stinging was a wasp. I wasn't paying attention. I went to take my trash can out. There's a wasp on the bottom of my trash can handle. I put my hand around there. Next thing I know, I felt like I'd touched a piece of glass, and I ripped my hand away really fast and watched the wasp fly away. Anxiety kicked in a little bit, I'm not going to lie, but it wasn't a huge deal. Killer bees, Africanized honeybees, they travel in packs. I'm going to tell you that. You don't just see a random African killer bee flying around. I'm not immobilizing and killing bees with a wetting agent. I'm going to go to a safe area and I'm going to put myself in it and I'm leaving, such as a vehicle. All right, let's take another 10-minute break. Come back here about 8:05. And I think we've only got like 30 slides left, 30, 40 slides left. So 8:05, come back and we'll finish up the slideshow.
Hey, Rudy, I have one quick question for you. Did you see the news about those? There's new like mosquitoes.
I did not.
Oh.
Mosquitoes are another thing I'm not a big fan of. You'll notice I'm not a big fan of bugs or snakes.
I see that.
And I've seen some mosquitoes, I swear to God, that were the size of small planes and that I think could have carried off children. So I'm just not a big mosquito guy either.
There was just something in the news about some new brand of mosquitoes that's supposed to be really highly venomous. So I just didn't want
to. I haven't seen it yet, and hopefully I don't.
Okay.
All right, let's wrap up this PowerPoint. So jumping into what I think is the most interesting part, having to do with spider bites, snake bites. I think it's interesting because I don't like them, to be honest. If anybody wants to chime in during this, please feel free, because I'm not an expert in spiders or snakes. If you know more than I do, by all means, you probably do if you know half this stuff. Brown recluse spiders, pretty common, especially in Iowa. Dark, dry locations, really common. And again, correct me if I'm wrong. One of my fears, I like camping during camping season. So I have a wood pile at my house of firewood that I will take every time I go out camping. One of my fears all the time, and I always put gloves on when I'm grabbing the firewood, is that I'm gonna get bit by one of these things. I don't know if I've ever seen one in person, or maybe I just haven't looked well enough to know what they look like. I know they have what's called a fiddle. They have a tiny little fiddle on their around their abdomen or on their back. That indicates that's what a brown recluse is. The problem is brown recluse spider bites are very necrotic. They will start to tear tissue down after a certain length of time. And when I say tear tissue down, I literally mean it'll look almost like kind of like a diabetic wound that's open and kind of like open flesh that's infected. That's what it'll look like after a little bit period of time. There's your little fiddle on its back. Has anybody in here had any experience with a brown recluse before? Again, I know they're common, so that's why I ask. Okay, well, that's good. Yeah, I can't say I'm gonna get close enough to see a fiddle on their back. I just don't have a desire. Don't do it. Again, I'm not getting close enough to know they have 6 eyes. Something good, I guess, is that bites are painless. The problem, again, isn't the immediate reaction that your body will have. It is the necrosis that will appear delayed. It will appear later on after the initial bite, if left untreated. And your body treats it just like any other infection or any sort of antigen. You develop a fever because your body's trying to, again, you raise your temperature because your body's trying to burn out whatever is attacking itself. Nausea and vomiting because it affects your central nervous system. Joint pain, potentially some hemorrhaging, especially if you start to get that tissue necrosis, but infection and sepsis is going to be pretty prevalent. I honestly don't know what the treatment is for a brown recluse spider bite, or even what they do in the hospital setting. Like I said, I'd actually sent an email to the ER director at Mercy today, asking about snake bites and spider bites, like what their protocol is as far as treatment and everything. I know they're pretty common here. Big thing that sets them apart, especially from anything else, is going to be that tissue necrosis, really. There's your initial bite. You can tell the massive amount of irritation that's, let me get my pen out, that's developing all the way from up, all the way down. To me, that's a pretty serious sign, knowing that the bite was initially pretty small. And you can even look at the wound there in the middle. It's starting to open up. Not a good sign. Black widows, another thing. Again, wood piles, dark, dry places. They're a little bit different to identify because they either have a red or orange spot on their abdomen. Again, for the regular person, I consider us regular people. We're not, looking at insects all the time. I can't say that I'm going to look at a spider and say, yeah, that's a black widow. I can't say that I'm going to get close enough to know to look for that little red hourglass on their abdomen. That means the underside of them. I'm not picking that spider up to determine if it's a black widow or not. Very potent. It affects your CNS system. So problem with black widow bites is that you can develop extremity paralysis. You can develop a seizure-like activity, even tremors in the extremity. It could initially feel really cold, like the extremity's been in ice water, and then it could go initially very hot. Again, you will start to experience some signs and symptoms of CNS, nervous system issues, muscle spasms, whatever it might be. I will tell you on my national registry, I did have a question about a spider bite. It didn't ask specifics on the spider. It just asked me to identify the bite. And the big thing for me was that localized swelling, that redness, and the two puncture marks in the middle that identified as a spider bite for me. There's its hourglass on its abdomen, usually red or orange in color, roughly. Anybody got any experience with any black widows by chance? Anybody have any run-ins with them? Maybe? No? The best thing that we can do for these patients is treat their symptoms. The biggest ones we're going to treat nausea and vomiting. Maybe if it's severe enough and they have seizures, treat the seizures. But really, we're going to be treating very minor side effects till we get them to the hospital. At that point, they're hoping, they're going to be fighting infection. They're going to be seeing what maybe in antibiotics, maybe there is some sort of anti-venom available, depending on what essentially they were bitten by. Again, scorpions, I don't think we have to be concerned about those here. I can't say that I've ever had a run-in with a scorpion anywhere besides the zoo. But deserts, overseas, scorpions are a big concern. My dad lived in Arizona for a while. He was very familiar with scorpions. Basically said you had to check under everything. If you left something outside, you left your shoes outside, you better check inside for a scorpion. You better look under anything that's outside that you're going to be touching to see if a scorpion's hiding underneath it. Just like snakes, they have venom. Whether you want to call it poison, whether you call them venom, I don't care. They deliver a certain amount. The difference is mostly with scorpions and spiders, they don't necessarily have a dry bite. When they usually bite, they're injecting venom almost every single time, as opposed to a snake. A snake can dry bite generally 8 times before you get a wet bite. And your dry bites are more of your quick, it's trying to warn you, like maybe, a rattlesnake, you walk really close to it, jumps out, bites you, and comes back. That might not have been a wet bite. It didn't probably induce any venom, but it got its point across. You'll know because if you start developing symptoms. Most venom is going to work on our nervous system. That's why seizures, nausea, vomiting, that burning and really cool tingling effect that I was talking about earlier. If severe enough, yeah, you can develop some of these. It used to be we put a tourniquet on and tied that sucker as tight as we could because we wanted to try to limit the infection to that limb or that portion of the limb or that portion of the blood vessels. They're not saying, they don't say tie it as tight as you can anymore. Really, they want it tied pretty loosely, to be honest. Really, what they're just trying to do is stop your smaller capillaries and everything from spreading it, which doesn't take that much pressure, to be honest. Avoid the use of pain meds if possible. I don't know if I agree with that. If somebody's in severe pain from that, I'm probably going to treat them with pain meds. That's something I would have to look a little bit further into to see if there is a contradiction. Maybe it could actually worsen their condition. In that case, yeah, I would withhold. But if it's for assessment purposes or something like that, I'm probably going to treat their pain 9 times out of 10. Snake bites, again, something we could potentially see here. We do have rattlesnake. We do have all these different types of, you're going to see them categorized in 2 different areas, pit vipers and more your, I call them flat-headed snakes, like gardener snakes, or, snakes that I'm not so much worried about poison. They're more like green in color. They're not very bright in colors. You know, we usually say, you know, red, yellow, black. Those are ones we get a little bit concerned about because they're a brighter colored snake. And also the eyes of a snake make a difference as well, which you'll see when we pull up pictures here. If you look at the eyes of that thing, first of all, it's terrifying. Second of all, its eyes are like a slit, like its pupils itself. They're vertical, right? That is indicative of a pit viper. They fall in that Viperidae category is the technical term for it, because the shape of their head, almost like a diamond shape appearance, along with their pupils, they fall into the pit viper category, as opposed to like an Elapidae, which doesn't have that diamond shaped head. It's more of a flat head, maybe rounded, and it has circular pupils. Rattlesnake again, you can see the pupils there, that vertical slit, vertical pupil going up and down. Rattlesnakes, generally, again, if you're encroaching on them, that's what the rattle is there for. It's to warn whatever, hey, I'm here. I can't be held liable for what happens next if you keep coming near me. Snakes, I don't care if you're 4 feet away from them, can jump. You know, when I lived in Oklahoma for a while, and if anybody has any experience with snakes, by all means, I lived in Oklahoma and Texas. There was a reason we wore thick boots, and it was for the simple fact that it would hopefully protect somewhat if you got bitten in the leg or in the lower leg or something like that. It wasn't uncommon for us to see rattlesnakes, but we generally tried to shy away from them as children, just because I really did. I did, at least. I didn't want to get bitten. And again, if you have any experience with rattlesnakes or any sort of snake, please speak up because I'd love to hear it. Copperheads, see the eyes, the pupils, you get that vertical up and down pupil. Again, almost like a diamond headed shape appearance. The head of a snake tells a lot. Pit vipers, again, Viperidae is the technical category for pit vipers. Triangular diamond shaped head. Their pupils are that vertical up and down, almost like a slit, as opposed to your Elapidae, which, you know, round pupils. The head is like the same shape as their body, to be honest. Problem is they can still be poisonous, such as your coral snakes. I'm not an expert. I'm not the guy that's going to say, again, I'm color deficient. I'm not the guy that's going to say, okay, yeah, hey, guess what? That snake's black and red. It's not poisonous. I'm not that guy. I'm going to shy away from the snake on the. I'm going to err on the side of caution. This was what I'm talking about. Mnemonic, red touch yellow, kill a fellow, red touch black, venom black. I'm not definitively 100% saying that. I'm just not comfortable with it. It's not that I'm super terrified of snakes. I mean, if it was a non-venomous snake, I'd probably pick it up. I mean, I'm on my yard. If there's a gardener snake, I usually pick it up and scare somebody else with it. But when it comes to larger snakes, I had a very bad experience when I first got into EMS. And I told this story earlier. I went to a mobile home for a guy having abdominal pain. He was sitting on the couch. I did my normal walk in. I got down on one knee, was talking to him, and out of the corner of my eye, I saw a tail go behind a couch. I had a moment where I froze and I panicked. I'm not going to lie. And I knew it was a tail of either a very large lizard or a very large snake. And I asked the guy, hey, do you have some sort of reptile in here? And the guy said he had a pet boa constrictor that he just let roam around his house. I was terrified at that moment. Granted, it probably wasn't there to eat me, but we finished our assessment outside of his home. Coral snake, red touch yellow, poisonous, red touch black, venom black. Might be something you might want to remember for your test because they could bring up colors of a snake. Again, you see that more rounded head appearance. It's almost in line with its body, as opposed to that. When I say rounded head, if the head looks like that versus, you know, looking like a diamond or a triangle, that's the difference between your Elapidae and your Viperidae. Again, I can't say for sure how many bites. I want to say I read earlier it was they can do 8 dry bites before they are going to administer a wet bite, which induces the venom or introduces the venom to the system. Is that a guarantee every time? No. I don't know. I don't study snakes. I don't know enough about them to see if that's like a thing that's on command. I don't know if that's a thing. Obviously, kind of like with our brown recluse, tissue necrosis is obviously a concern, as well as CNS depressant. Infection-like symptoms: swelling, continued oozing at the site because it's injured, weakness, dizziness, sweating, chills, excessive thirst as well, nausea, vomiting. I mean, this is a ton of different potential signs and symptoms. Somebody that's been bit by a snake. When it comes to if you respond to somebody bit by a snake, maybe you have a bike trail in your area, maybe you have a wooded walking path, whatever it might be. I know if you're in central Iowa, you're not far from rattlesnakes. Winterset, Madison County has a ton of rattlesnakes in it. Southern Warren County has rattlesnakes. Western Warren County has rattlesnakes. I can't definitively say if somebody's bitten. They're probably not chasing the snake down to kill it, to hold it there until we get there. We might not even know what they got bit by. But if they tell you they got bit by a snake, take it for face value. Take it for what it is. Treat their symptoms. There you go. 25% of rattlesnake bites dry, no venom injected. I don't know what that accounts to. Amount of venom varies significantly as the degree of envenomation. So how much venom they are injecting. When we talk about envenomation, that's how much venom are they injecting into whatever they're biting. Antivenom or antivenom considered only for severe cases. I think that's 100% true. If there's concern for infection, tissue necrosis, then they're going to look at giving some sort of antivenom, depending on how severe it is. And again, I'm waiting for an email back from Mercy because that's kind of good information to know. Is I want to know if they do carry antivenom there. And I'll probably reach out to Methodist as well, just to kind of see, to know which hospitals. I know, and again, if you're in an area, your hospital that you think they carry antivenom, speak up. Just so for reference, I had a guy earlier today in class. I don't remember who it was, but his service, they carry antivenom at their smaller hospital, just because they're in a rural area, they might not have the possibility to transfer somebody right away, so they keep that there in case somebody gets bitten. Immobilize the extremity. I'll tell you, transport them in a position of comfort. Don't apply a tourniquet, which is opposite of a spider bite. Supportive care. Treat the patient's symptoms. 100% supportive. Again, I highlighted do not apply a tourniquet because that will come up in National Registry wise. Coral snake bites, again, round-headed. Symptoms are pretty much the same. We won't have a definitive way of saying what it is that bit them unless we can see the snake. And again, treatment's gonna be the same. Immobilize, supportive care. Treat, transport in the position of comfort. Wash, irrigate the wound if you can. Saline, distilled water, whatever it is, just to try to get as much of that as you can out. Obviously, it's back in the day they used to think it was a great idea to suck the venom out of somebody's wound. Not a great idea, I don't think, in my opinion. Don't incise the wound. Don't cut into it. Don't open it up. Not a good idea. You're introducing infection. Marine animals, the ones that I was familiar with as a child, I was very familiar with jellyfish. My brother actually had a run-in with a jellyfish. Oh gosh, probably 10 years ago. We were down visiting family in Florida, and another one is stingrays. Most recently, during spring break, we went pier fishing down in Florida, and while I was down there, I actually caught a stingray off the pier, and it's not something you can just reel up and pull off a hook. I mean, the DNR had to come over. They had a basket they'd lower down, bring the stingray up. They had essentially used something to hold it down to get the hook out of it, because stingrays can be fatal. I mean, I'm not trying to point fingers here, but Steve Irwin, I'm just throwing that out there. They do inject toxins. You know, my brother, he was, God, 14, 15 at the time. He was sitting in like a pool noodle that had a net on the bottom, and it kind of like he floated in the ocean a little bit on this noodle. Next thing we know is he hops out of this. He's hysterical, freaking out. Inside the net is a giant jellyfish. Of course, it caused irritation, it caused stinging. But he didn't end up going to the hospital or anything like that. Actually, there was a sheriff's office trailer on the beach that they were able to. They had some sort of cooling spray or something like that they put on him to take away the pain at least. But he was irritated and had a wound for a little bit of time. Man-o-wars is essentially a giant jellyfish. That's what I call them, at least. But again, this isn't something we're necessarily going to have to worry about. When it comes to a venomous animal, I don't care if it's a snake, I don't care if it's a spider, I don't care if it's a sea animal. We treat them a little bit the same, right? Supportive care. We're looking for those common signs: the swelling, the CNS signs, weakness, nausea, vomiting, treating for shock. Here in this case, you apply heat instead of cold packs. Marine animals, you apply heat. Remove any stingers if possible. Very short section, so I highly doubt you're gonna get any questions on marine animals, to be honest. How many slides do we have left? I feel like you guys are dragging here. Oh, we've got 12 left. Bear with me. Substance abuse and overdose. Very common. Something we're very frequent with, right? People that either want to abuse pain medications or, like I said, benzodiazepines. They become dependent on these medications. The problem is, as they become dependent on them, they also build up a tolerance to these medications. As they build up a tolerance, they have to keep upping their dose when they are addicted to something. When they essentially quit cold turkey, they can have withdrawals, kind of just like with alcohol. They can develop tremors. You can obviously see that physical reaction within them. They can have anger outbursts. Where they're, as you can see, their conflicts with family, friends, coworkers, just for the simple facts that you're taking something away that their body needed every day. Their body had built up that need for whatever it was, and now that's gone. They'll do whatever they can to support their habit. You know, like I said earlier, we had an issue here in the Des Moines Metro of people stealing Freon from people's air conditioning units. They weren't doing it to steal it and sell it. They were doing it because they didn't have any means to get their high that they needed. Illegal? Yes, absolutely. The problem is, as their tolerance builds up, they keep on having to give themselves more and more and more until they potentially overdose. In that term, that's where we kind of step in. Biggest one that we've seen recently is obviously our fentanyl and our opioid overdoses. I think that trend is going to continue a little bit. What we've also seen is laced ecstasy. We've seen laced Percocets, Perc 30s, all different types of medications that people are essentially cutting and introducing fentanyl or something else to just to kind of, enhance their high. The problem is they don't look at what the potential consequences of those are. Depending on the substance, the patient could present a little bit differently. Is it a pill? Is it an injection? Especially, I had a patient again that I could not get an IV on this patient to save my life. And I remember one time specifically, she told me, just give me the needle. I bet I can get it. It's their lifestyle. And, looking for those injection marks, looking for the signs of people that are abusing substances. I honestly feel for these people because some of them are so addicted to this that they can't get off because there really is no help for them. Really, their signs and symptoms and how they're going to present is going to be dependent on what they are taking. Opioids pinpoint pupils, respiratory depression. Cocaine is more of a stimulant, so you're going to see higher blood pressure, more activity. They're going to be really hyper. Some stimulants such as bath salts. That's when we were getting that excited delirium. Even some of our synthetic marijuana, like K2 was big for a while. I don't know what the new one is, but we were seeing some side effects there that were not the greatest. And the problem with that is that it's all legal until it's outlawed, and then they just change one ingredient in it, and it's legal again because it's not what the ingredients were of the outlawed one. Alcohol is the biggest substance that is abused in the United States. Again, thiamine, vitamin B, may be required for chronic alcoholics. If they are hypoglycemic, we're going to be giving vitamin B and D50 if we have it. Benzos, our Versed, our Ativan, our Valium, those are medications that are sought after because they create that euphoric effect. One of the ones that people constantly get their hands on is alprazolam. That's a common medication prescribed to people with anxiety. Cocaine, I would say what we would most commonly see, and it's a big thing now, and I hate that I don't want to get on tangent about drugs, but cocaine is very freely moved throughout the United States. Generally comes from the South, moves its way up, and more of the desolate and poorer populations, you're going to see crack cocaine. It's a lot easier to be manufactured. It's a lot cheaper for them to purchase, but the effects are going to be the same. Again, the problem is they build up a tolerance after so long that they keep having to up their dose of how much they're taking. Hallucinogens, ketamine was a big issue for a while because people would try to get their hands on ketamine. They'd break into vet clinics to get their hands on ketamine just to get that hallucinogenic effect. Mushrooms, obviously our narcotics and our opioids, which we are very familiar with for our Narcan. It can trigger, obviously, withdrawal reactions. That's when we see those patients we give Narcan to, they start to wake up maybe in a combative fit. We got to be a little bit concerned with that. Drugs for sexual purposes. Ecstasy was, the nightclub drug. That was the drug that was supposed to be, to get you all amped up for partying. When I was in high school, ecstasy was a big thing. It had different labels on it. It had different stamps on it to make it look like it was a legal medication. It came in different packages. Rufalin or Ropanil, date rape drug. Pretty common again in the nightclub scene for people that were trying to essentially cause a state of unconsciousness or a state of altered mental status so they could essentially take advantage of somebody. It really was sedating them, to be honest. Again, alcohol. You'll see people. I had a patient. He ended up passing away. Was so chronically addicted to alcohol. His family removed all the alcohol from the house. Was trying to get him to withdraw and quit drinking. He turned to antifreeze because one of the ingredients in antifreeze is alcohol, ether or ethylene glycol. And what ended up happening was he drank half a bottle of antifreeze. It had the same effect. Problem was it demolished his liver. I want to say within 24 hours he was dead. And basically when we got him to the hospital, the doctor basically said there's nothing we're gonna be able to do for him. There's nothing at this point. And that's something that you could potentially see is people drinking antifreeze to get their substance they need to replace their alcohol. He wasn't really exhibiting any signs besides an altered mental status. His family's the one that found him and found the antifreeze bottle next to him. He wasn't having seizures or anything like that. He'd had urinated himself, so maybe he'd had a seizure prior, but I really didn't see anything crazy out of whack. His blood pressure was really low. His heart rate was pretty low. I was just pumping fluids into him, trying to get to the hospital pretty quickly. And again, within 24 hours, he'd passed away. Generally, alcoholics, they believe they can impair their drink, or they can control their drinking. In the end, they really can't. They don't even think about it. And, drinks early in the day, yeah, they might start in the morning, and they have to do it to get through the day. Unfortunately, I use to be honest, my dad as an example. My dad is what I consider a functioning alcoholic. He has to have alcohol to function, and you'd never know he's drinking. It's just how he functions. And it's just not a good life, to be honest. Prone to drink alone, secretly. You don't have to be around people. You're not a social person. You'd rather be by yourself and get intoxicated, go through your own thoughts. Those are the people that kind of worry you a little bit. Loss of memory. They don't remember things that happened yesterday, day before, because they were drinking too much. And again, it's very much like drugs. They have to keep upping how much they're drinking because their body builds up a tolerance to it. Cigarette burns on clothing because they're passing out. They're dropping cigarette ashes, cigarette cherries on themselves, burning their clothes, burning their couches, wherever they're at. That's also where you see a lot of house fires come as well, is generally a lot of times alcoholics that had fallen asleep or somebody had passed out with a cigarette in their hand. Poor nutrition, they're generally really frail. A lot of times they have tremors. After a period of time, their liver can start to shut down. They will get that cirrhosis, that hardening of the liver. They could potentially develop hepatitis. They could start to jaundice after a period of time, and they really lose total fine motor function of some of their extremities just because of those tremors. And one thing to think of as well is if you have somebody that's coming down off alcohol and they have DTs, delirious tremens, it's almost like seizure activity, but it's not a seizure. It's their body is literally tremoring because it's withdrawing. It hasn't had that alcohol. It needs it. Chronic alcoholism can lead to pancreatitis, severe hypoglycemia. Again, that's why we're giving vitamin B with our D50 because they are malnourished generally. Potentially have bruises. My grandfather was a pretty heavy drinker as well. He developed pancreatic cancer. It spread pretty quickly. He was a textbook. He was probably weighed 90, 100 pounds maybe. Was tall, lanky, was very shaky, almost like he had Parkinson's. And that's how I kind of relate some of this stuff back to. We've all seen what an alcoholic looks like, especially when we go on these calls. And again, some people I generally am empathetic for, just because of I don't know what situation somebody's going through or what somebody is potentially dealing with. All right, end of the slideshow. Any questions? No. I can't remember if I showed you guys or not. Did I ever show you guys? I was going to show you guys in person, but might be easier to show you on this. That video of that Netflix series about the lady that it's called Heroin. Has anybody ever seen that? Did I show you that to you guys? I can't remember.
No.
Okay, I'll pull it up real quick. Just if you want something interesting to watch, it's like a 2-series thing on Netflix that you can look up or even on Amazon. And then I'll be done for the rest of the night, and you guys can do with what you will for the rest of your night. But it takes place, I want to say Huntington Beach, Ohio, if I'm not mistaken. And it was at the height of the epidemic crisis. And it follows different people during this crisis, from users to fire department to the judicial system, watching how these people function, how these people essentially get by and follow their day-to-day life. So I'm going to share my screen real quick. This is like it's the 2-minute video. So I just want to make sure you guys can hear it. All right, you guys can see that, right?
Yeah.
Okay.
Patient is unconscious.
I see this as a problem that has the potential to bankrupt the country. It's sad when you can drive around the city and say, oh, somebody died there, somebody died there. Right where you were doing so good.
I lost my job and shit. I can't help it. This is the only place I can turn to.
I can't tolerate you lying to your probation officer.
This is our community. We will not be defined by this problem.
Don't shy away
I want to give you some direction and some structure.
Usually come out one night a week and we just give you some food.
Our parole officer didn't expect nothing from me.
We don't roll that way, do we?
Right, no, man.
Today's special day?
5 months clean.
5 months clean? And I don't care if I save somebody 50 times. That's 50 chances to get into long-term recovery.
It's, again, a hell of a little series. If you ever have free time to watch it, I know your paramedic student and free time is very far and few between, but it really opened my eyes as to things we don't see here in Central Iowa or in the Midwest, as to what's else is going on in the country, as far as opioid and crisis, having to do with fentanyl and, you know, people overdosing. It's again, pretty informational to watch. The rest of the semester is going to be pretty easy. I'm not going to lie to you guys. A lot of our chapters, like tonight, and then our next one's a long one as well. I think it's the same amount of slides. But after that, like, we're going to do like 2 chapters in one night, and they're probably only like 100 slides combined. What I will tell you is focus your note-taking time on the stuff you don't know. If it's something you know, maybe don't spend as much time studying that and study the things you think you need a little bit more work on, whether it's cardiology, respiratory, whatever it might be. Don't get so caught up in the chapter we're going over, especially if it's something that is pretty familiar to you. Like when we go through like, non-traumatic bone disorders, such as osteoporosis and calcium deficiencies and stuff like that. It's pretty self-explanatory. It's a pretty short chapter. I think it's like 40 slides. Maybe don't spend as much time on that as you would the chapters that are 200 slides, because those have more of your core content as opposed to the other ones. So just a little tip for you guys when we're going through this. You guys are on the downhill slide of paramedic school. You know, you have crested the hill, you're going down. Next semester is mainly all review for everything in paramedic school and finishing up your clinical and field and make sure we get that all knocked out. I mean, you guys have literally, we talked about today, a little bit more than 4 months left and you're done. That's, you know, some people, I said it to the class today, it's kind of terrifying to think about. 4 months and you could be testing to be a paramedic. So you've all come a long way. I mean, truly, I've watched every single person develop in your knowledge, especially, you know, when we talk about cardiology, medications, pharmacology, whatever it is. It's a good feeling for me to be able to watch you guys do that. And that's part of the gift of my job, is watching you guys progress. But you're on the downhill slide. You guys are doing fine. Keep your head up. Keep going through. You guys will pull through. Do you guys have any questions before I end the class? All right. As always, if you need to get a hold of me, send me an email. Get a hold of me on Teams. Obviously, last week I was in Florida for vacation, so I wasn't really responsive. But I've unburied myself from all my emails today and yesterday. So shoot me an email if you guys need anything. Otherwise, I will see you during skills or when I see you. And then for the May City guys, I will see you this weekend.
Thank you, Rudy.
Have a good night, guys.
Thanks.
Thanks.